Buongiorno. It's really an honor for me to be here today to give this lecture to you. I'm going to speak about adjuvant therapy for muscle-invasive bladder cancer. Where are we and where are we going? These are my disclosures. When we think about neoadjuvant or adjuvant therapy for muscle-invasive bladder cancer, we know that patients with PT3, PT4, and N-positive disease have poor survival rates of 50% at 5 years after cystectomy. Recurrence is due primarily to systemic metastatic disease at the time of diagnosis, and we know that cisplatin-based combination chemotherapy is effective in metastatic disease. We have evidence that it prolongs survival as neoadjuvant treatment, and in most countries, immediate cystectomy, unfortunately, is what is preferred. These are the results of the EORTC study of neoadjuvant chemotherapy with CMV, that's cisplatin, methotrexate, and vinblastine, versus no chemotherapy. And the treatment of choice, definitive treatment, was left up to the investigators, was either radical cystectomy or radical radiation therapy. If we look at the median follow-up at 8 years, there was a 16% reduction in the risk of death and an overall survival benefit of 6% at 10 years in this large study of 976 patients. If we look at the group of patients who underwent radical cystectomy, there's a 26% reduction, relative reduction in the risk of death in those patients who underwent radical cystectomy after neoadjuvant CMV. The SWAG group in the United States, this intergroup trial, did a study of MVAC neoadjuvant chemotherapy, and compared to surgery alone, there's a 66% greater likelihood of death resulting from bladder cancer in those patients who did not undergo neoadjuvant MVAC chemotherapy. So these results are similar to those seen with the EORTC results. The meta-analysis collaboration group looked at patients who had randomized trials of cisplatin alone or cisplatin combination chemotherapy. And what they were able to see is that there was clearly a benefit for those patients in overall survival who had neoadjuvant chemotherapy. You can see an absolute benefit of 5% at 5 years in those patients who had cisplatin-based combination chemotherapy prior to definitive therapy. This is different from what was seen in the adjuvant trials. There were over 3,000 patients in the original neoadjuvant trials, and there was only 491 patients in the adjuvant trials. You can see that the boxes are very small. The hazard ratios are extremely, extremely wide. And although this looks like a positive trial, the wide confidence intervals makes one clearly wonder. There was a 9% absolute benefit and a 25% relative reduction in death, but the authors themselves said that interpretation of this meta-analysis is limited by the small patient numbers and poor study quality. For this reason, we started the EORTC 30994 adjuvant trial. We initially planned to have over 800 patients and ended up with only 284. Unfortunately, patients were eligible if they had PT3, PT4N positive disease and were after cystectomy within 90 days. They were randomized 1-to-1 to receive immediate therapy with gemcitabine, cisplatin, or MVAC, or high-dose MVAC for 4 cycles. We were not comparing the different kinds of chemotherapy or deferred therapy at the time of relapse, with the primary endpoint being overall survival and secondary endpoint progression-free survival. What we saw was a highly significant improvement in progression-free survival in the intent to treat population. At 5 years, the progression-free survival was 47.6% as compared to 31.8%. The median was 3.11 years as compared to 0.99 years. That's a difference of 2.12 years. The hazard ratio is 0.54, and this was highly significant. Now, if we look at the overall survival, which was our primary endpoint, there was a non-significant reduction of only 22.2% in the risk of death. At 5 years, it was 53.6% overall survival and 47.7% overall survival at 5 years, median 6.74 years and 4.6 years, a difference of 2.14 years. Again, there's only some 200 patients in this trial. This may be one of the reasons, or perhaps this trial was not followed long enough. If we look at the node-negative patients, what we see was really quite interesting. At the 5-year survival for the node-negative patients was 79.5% as compared to only 59% for those who were who did not receive adjuvant therapy. Hazard ratio highly significant, 0.37. The medians here are not really reached, which is important to notice. And if we look at the patients that were node positive, here you can see there was really no difference on whether they did or did not receive adjuvant chemotherapy. What we did in this paper was we took we added these results of the EORTC trial to all of the other results that had already been in the literature. We did not have individual patient data on everyone. So this is an updated literature-based meta-analysis of the studies of adjuvant therapy. But what we did show was clearly that it looked that adjuvant chemotherapy was an important in terms of overall survival for patients. What we do have now is a adjuvant chemotherapy systematic review and meta-analysis with individual participant data from randomized controlled trials. And this was led by the MRC. And we were able to obtain all of the individual patient data from 10 different trials to really increase our numbers from the 491 originally in the adjuvant study meta-analysis. We have 10 randomized clinical trials with over 1,183 participants here. And you can see that we have much more data to look at here in this meta-analysis that was just recently published in European Urology. The hazard ratio of 0.82 is highly significant in favor of adjuvant chemotherapy. And if we look at the absolute improvement on survival with adjuvant chemotherapy of 6% at 5 years, from 50% to 56%, and a 9% absolute benefit was seen. So we can see that the results are really similar to what we saw originally with only 491 patients, but with many more patients, I think that these results are much more significant and do show the benefit of adjuvant cisplatin-based chemotherapy. If we look at the effect on overall survival, adjusted by age, sex, PT score, stage, and PN status, there's really no difference in the results that were seen, and the hazard ratios are really very, very similar to what was seen in the whole population. What was interesting was that there was really no difference seen depending upon pathologic stage, and what we did see was something similar to what was seen in the RTC study, that there was a lesser treatment effect with a higher lymph node status. Again, must remember that many of the patients in this meta-analysis do come from that EORTC study, which was the largest study yet published on adjuvant chemotherapy. Adjuvant chemotherapy in this meta-analysis improved recurrence-free survival, the hazard ratio 0.71. Adjuvant chemotherapy improved local recurrence and progression-free survival, hazard ratio of 0.68. This is an absolute benefit of 11%, as was here, again, an absolute benefit of 11% in recurrence-free survival. And adjuvant chemotherapy improved metastasis-free survival. Here, the absolute benefit is 8%. So this systematic review and meta-analysis based on updated individual patient data demonstrate that cisplatin-based adjuvant chemotherapy is a valid option for improving outcomes for muscle-invasive bladder cancer. I'd like to switch gears for a moment and speak about adjuvant nivolumab. This is immunotherapy, anti-PD-1 therapy versus placebo in muscle-invasive urothelial cancer. And these are new, really interesting data. This is Checkmate 274. It's a phase 3 randomized double-blind multi-center trial with adjuvant nivolumab versus placebo in patients with high-risk muscle-invasive urothelial cancer. 709 patients from many countries were enrolled into this study. The patients either had neoadjuvant cisplatin chemotherapy or they had PT3, PT4, or PN1 muscle-invasive urothelial cancer without prior neoadjuvant cisplatin chemotherapy, and they were thought to be ineligible or they refused adjuvant cisplatin therapy. The radical surgery was within the past 120 days and disease-free status within 4 weeks of dosing. Patients were randomized 1-to-1, stratified according to their PD-L1 status and whether or not they'd received prior neoadjuvant chemotherapy, and randomized between nivolumab IV every 2 weeks versus IV placebo. And patients were treated for up to 1 year. The two primary objectives were disease-free survival for nivo versus placebo in all randomized patients, and to compare disease-free survival for nivo versus placebo in all randomized patients with a PD-L1 status of greater than 1%. If we look here at the patient characteristics, you can see that 79% of patients did have urinary tract bladder disease, but that 21% had upper tract disease only. If we look at the PD-L1 status being more than 1%, this occurred in 39.7%. And we look at prior neoadjuvant cisplatin therapy, only 43.3% of the patients had had prior neoadjuvant cisplatin therapy. And I think these data will be looked in more carefully in the future. If we look at disease-free survival, the intent to treat analysis was positive in terms of disease-free survival, and nivolumab was clearly better than placebo. And in those patients with PD-L1 score of greater than 1%, we have a really significant hazard ratio here of 0.55. And looking at nivolumab versus placebo, you can see that the nivolumab arm did much better. If we look at disease-free survival in select subgroups in the intent to treat patients, if we look at the patients with upper tract disease, renal, pelvis, and ureter, the hazard ratios are crossing 1. The effect is clearly much stronger in those with urinary bladder tumors, but again, there are smaller numbers in the upper tract tumors that we're discussing. Also, if you look at the patients who had no prior neoadjuvant cisplatin therapy, and there's quite a number of those patients, you can see that these patients, again, seem to have had a little less benefit, again, crossing the hazard ratio of 1 than those who had prior neoadjuvant cisplatin chemotherapy, but they did have a benefit in any case. If we look at non-urothelial tract recurrence-free survival, both the intent to treat group did better with nivolumab versus placebo, and in those with PD-L1 positive, once again, with a hazard ratio of 0.54, the patients with who had nivolumab did much better than placebo as well. We look at distant metastases-free survival in terms of intent to treat. The patients with nivolumab did better than those who had placebo. And again, the patients with a PD-L1 score of more than 1%. Again, the very significant hazard ratio of 0.60 did better with nivolumab versus placebo. This is a volcano plot looking at the toxicities, and there were more toxicities seen in the nivolumab arm. And in fact, there were 2 treatment-related deaths due to pneumonitis in the nivolumab arm. This is a rather unusual. We do see pneumonitis with nivolumab. Most of us know how to treat this. We must examine our patients carefully, stop the nivolumab, give corticosteroids. But again, this was an international study done in many, many different countries, and these were the results. I'd like to conclude by saying that perioperative cisplatin-based chemotherapy, whether neoadjuvant or adjuvant, for bladder cancer is the standard of care based on meta-analysis, based on individual patient data. And we now have that not only for neoadjuvant chemotherapy, but we also have that for adjuvant chemotherapy as well. Adjuvant nivolumab has significantly improved the disease-free survival in patients with high-risk muscle-invasive bladder cancer after radical surgery, both in the intent to treat and in the PD-L1 positive populations. And we can say that probably it has improved in muscle-invasive urothelial cancer, although the results are not as significant as in the muscle-invasive bladder cancer patients. Nivolumab monotherapy is a new standard of care in the adjuvant setting for patients with high-risk muscle-invasive bladder cancer after radical surgery and prior neoadjuvant chemotherapy, regardless of PD-L1 status, and the overall survival results are still awaited. Thank you very much for your kind attention.